Good afternoon, everyone, and thank you for joining us today for our workshop for this rulemaking. I'm Amelia Boyd, and I'm the program manager for the commission and organizer for this webinar. Meeting will be recorded and will be made available soon on our YouTube channel. Please note that I have a visual impairment, so for accessibility, documents today may be displayed in a larger font and in dark mode. This means the background will be black and the text will be white. The documents we'll be discussing today are also available on our website, which is wmc.wa.gov. You can navigate to our website by clicking on the globe icon on the screen. Attendees, if you have a question or would like to make a comment, please use the hand function. Your questions and comments as possible. When offering comments, please do try to avoid reading aloud any written remarks that are already included in the materials. We don't have any written remarks included in the materials, so these workshops are intended to be collaborative with a back and forth exchange of ideas about language. So I will now begin the roll call of panelists and staff. When I call your name, please introduce yourself. So go ahead, Marlon.
Good afternoon. My name is Marlon Basco. I'm a policy analyst at DOH, and I support Amelia with rulemaking efforts for the commission.
Thank you. Go ahead, Christine.
Christine Blake. I'm a public member of the commission.
Curry.
Diana Curry. I'm a medical commissioner, OBGYN specialty.
Mr. Farrell.
Hi, Michael Farrell, supervising staff attorney with the commission.
Bonnie.
Hi, Bonnie Gregory. I am part of the WMC staff and administrative assistant for Amelia.
Thank you. And Heather.
Good afternoon, Heather Carter, Assistant Attorney General, legal advisor to the Commission.
Dr. Domino, please introduce yourself, and then you may begin the.
Hi, I'm Karen Domino. I'm a commissioner and I'm an anesthesiologist, and I'll be leading up this workshop. My name is Karen Domino. I'll be the presiding officer for the rules workshop. Today is Monday, October 20th, 2025. It is now 1:34 p.m. Pacific Daylight Time, and this meeting is being held by a Teams webinar. The rule being discussed today is regarding the use of nitrous oxide in office-based surgical settings. The CR-101 or pre-proposal statement of inquiry was filed on May 17th, 2024 as WSR number 24-11-104. Ms. Boyd, please discuss the proposed rule development timeline and introduce the suggested revisions to the draft language.
So here's our proposed rule development timeline. We actually held a rules hearing for this meeting, or for this rule, on August the 22nd. But at that hearing, the language was not adopted, and it was sent back for more interested parties' work. So we hope that this is the last workshop for this rulemaking. If so, then we will bring this one forward at the November 21st business meeting for the commission, and they will discuss whether we want to move back to the CR2 and move on to make this permanent rule. And then, so for our draft language discussion today, we'll be reviewing and discussing the revisions made based on suggestions from that rules hearing from August 22nd. All the suggested revisions are in the proposed new section, which is WAC 246919603. The first revision is in subsection 1, and it adds clarifying language, and we will go into that in just a second. And then the second revision is in subsection 2C5, which is V, clarifies that who makes the nitrous oxide provider. And then the final revision is in subsection 2C, little x, big A, big B, which adds language addressing alternatives to scavenging systems. And then we received a couple of late comments, which we will also discuss as part of the draft language. So let me stop sharing this and share the draft language. Okay. So here is the first revision. Technical. So again, if there's not a note about the suggested change, these suggested changes are from the hearing. So there was a robust discussion at the hearing about some changes that we needed to make. And so this is the first one that was suggested, and it just says that section, which it means is not applied to facilities that hold accreditation or certification from an accrediting organization approved WAC 246-919-601-5A. And if you would like to see that section, I can pull it up. It's it used to have a list of all of the accrediting organizations that were approved, but now we keep that list out on our website. So that is one of the suggested changes. It just clarified who's exempt. Do you have any questions about this change?
Yeah, Amelia, can you go over again which, because I recall most of the people commented at that meeting didn't participate earlier in this, and I don't know, like, I know Planned Parenthood was one, but I don't know what other ones were, and just to refresh our memories of what groups don't have something else that they're following.
So give me just a second and I will go pull that list up. I will click on a different page. So let's see. And then I will share it in just a second. Okay, the list lives out on our policies page under WMC administration. And this is the like procedure for how we do the approving, but this also contains the list. And the list is on the last page. So it's all of these that are approved on the list. So they are exempt from 603, the new section 603.
Can I ask a question? Karen, were you asking who were the clinics and things that are not accredited by these institutions that were requesting that particular change in our rule? Is that what I thought? That's what you were asking, not what the list of accrediting organizations was.
Yeah, I was just, Planned Parenthood is here.
It was like Cedar River, it's some of the safety net, small,
safety net places.
yeah, office-based procedure, especially women's healthcare types of places. So that don't have like ambulatory surgery type facilities, as I recall.
Because they were just exempt from this. We're talking about more of, these aren't hospitals either. These are office-based procedures, but are different than those, right? So they don't have to follow what we say.
If you want to know who all commented, I'd have to go.
Oh, no, that's okay. I
and I
just
can do
was
that.
trying
It'll
to,
just take me a
because
minute.
there
Okay.
was confusion, and then Heather mentioned a whole bunch of things about that. Some of the things are not relevant to those facilities because they're not covered by this.
Right.
Right, they're exempt.
Yeah.
And that's
Yeah.
why
Okay.
we needed to add this particular change.
Yeah, I think it's good. I just didn't know if people know that they're
I agree.
exempt and if we need to have a list of what examples.
I think they should know. I think this is good language and we should accept it.
Agreed.
Dr. Domino, are you okay with that?
Yeah, it's fine. I mean, if they know, it just seemed like from the rules hearing no one knew that they were exempt.
Right,
Yeah.
right,
I mean, the organizations didn't, as well as us. So
right.
that's okay. I'm happy to have it shorter.
Okay, and for this next one, it came from Planned Parenthood and it was a comment we received on Friday, so it is not in the meeting materials. I can pull up the comment. Let me get that real quick so we can see the full. So here's their comment, and their suggested change was on that previous screen, and we can go back and talk about it. But this is, I'm going to just read this real quick, and then we'll go back and discuss their suggested changes. So Planned Parenthood organization in Washington State, Planned Parenthood Alliance Advocates Washington PPAA appreciates the opportunity to provide feedback on the WSR we're talking about today, office-based surgery rules, use of nitrous oxide. PPAA appreciates the proposed language, reducing the burden of a scavenging system and the added exemption for certain accredited facilities, and we recommend some additional minor adjustments to the proposed language. Excuse me. PPAA is thankful for the Medical Commission's efforts to ensure that Planned Parenthood and other accredited clinics can continue to provide nitrous oxide care to our patients for pain management and anxiety. Locations that are accredited already meet high safety standards and are regularly reviewed for up-to-date policies and protocols, which ensures the high quality of care for our patients. As such, we appreciate the clarification of the added sentence to WAC 603. This section does not apply to facilities, that one that we just talked about. To be crystal clear, we recommend making it explicit that such facilities are exempt from both WAC 246919601 and WAC 246919603. Therefore, instead of placing this exemption under subsection 1, we recommend adding the following language to subsection 2. And we will talk about this change in just a minute. And then it says that PPAA is deeply grateful for the Medical Commission's proposal to eliminate the scavenging requirement for demand flow equipment. This change ensures provider and patient safety while eliminating the cost-prohibitive facility renovations and upgrades that would have been imposed on safety net providers. This change is also consistent with interpretive guidance and OSHA recommendations on dental providers. They go on to say, as currently drafted, Section 2CV mandates that a licensed healthcare provider who is not the physician performing the procedure administer the nitrous oxide, as we stated in our previous comment, for simply gynecological procedures. Often non-licensed staff, like certified and registered medical assistants, assist physicians and licensed advanced practice clinicians, such as physician assistants, whose scope of practice allows some gynecologic procedures. These unlicensed staff are well trained and routinely staff procedures and monitor patient vitals in clinics. Under the Commission's current interpretive statement, a certified or registered medical assistant can assist the physician when administration of nitrous monitoring. We urge the Commission to eliminate 2CV and continue with existing guidance that allows unlicensed providers to assist the physician or clinician providing the procedure, or otherwise allowing unlicensed trained medical personnel to assist with administration and monitoring by eliminating the under 2, I think they meant CV. Planned Parenthood organizations in Washington are proud to provide nitrous oxide to support our patients with a pain and anxiety management option. We appreciate that the Medical Commission is moving forward to provide more certainty and guidance around safety measures when administering nitrous oxide in clinic settings, and we respectfully urge the Commission to include the adjustments proposed above. So this is their first suggestion, is that we add this language here for facilities that hold accreditation or certification, which we're kind of saying up here, but they're wanting us to like reiterate it in this section. I don't know how you feel about that. It already says that this section does not apply to those folks in 6015A.
Amelia, we've got a hand raised from Heather.
Go ahead, Heather. Thank you, Bonnie. Oh, you're muted, Heather.
Oh, I'm sorry. So on that issue, I would just put it one place. I don't think you need it multiple. And then just commenting on the letter that you wrote about them being exempt under 601. And I don't think that's accurate. They are listed as they are one of the approved entities. They still have to comply with 601.
Gotcha. That's important.
I like the,
Go ahead.
I was going to say, I like it in section 1, the way we have it, because it just is really clear. And adding it again in section 2 makes it sound like we mean something different from the thing we just said before. So I agree we shouldn't say it twice, and I kind of like the way it sounds or stands out at the end of section 1.
Okay. Other comments from Dr. Domino and Ms. Blake?
Yeah, I agree getting rid of out of 2. It's not necessary.
Thanks.
Okay.
Amelia, I'm still confused over this 601 thing because I think one of the things we were trying to do is make it very clear that these groups don't have to follow this, right? And I don't really, so I'm confused because you said they're not under 601, but there's WAC 246-919-6015A that's listed on, I can't tell what page it is.
Right.
No page
So, and I can
numbering.
pull it up. I can pull it up here too.
So can I ask a question while you're pulling it up?
Go ahead.
I thought, so Planned Parenthood can accredit a facility, but that doesn't mean they do accredit every single facility that they have, is my understanding. So if they have accredited their location, whatever it is, that's fine, they'd be exempt. But if they haven't gone through that accreditation process, then they would have to follow this rule. That was my understanding, but I may be confused. So Heather, you were sort of
Yeah.
like nodding. Is that?
Yeah, I think that's right. So 601 is for office-based surgery, and it's when you're using moderate or deep sedation. And in those cases, you have to be accredited by one of that list. Joint Commission, blah, blah, blah. Planned Parenthood is one of those entities that can accredit so that they can do office-based surgery with moderate or I think moderate or deep sedation, but not general. So that's 601. And in 601, it talks about these are the accreditation groups that the criteria they must meet, and then the commission has approved that list. So 603 is now saying, okay, if you're just using nitrous, you're not doing moderate or deep, you're just using nitrous, and you're approved by one of those groups that we accept for moderate and deep, then you don't have to follow our nitrous requirements because we think you meet your accreditation works for us. Like that's good enough. But if you aren't accredited, you need to follow our nitrous rule.
Which may be the case in some of the smaller
Could be,
facilities,
yeah, it could
right?
be that some of the Planned Parenthood clinics might not be accredited fully with their own organization. That's true.
Right.
Yeah,
Yeah,
well, I'm
just-
not so concerned about young women. I'm concerned about old men. And because they're the ones, you know, they need less drug in order to become deeply sedated. And especially when people are using other adjuvants to it as well, such as benzodiazepines, which are also terrible for old people. So I just wanted to, so it seems like it's basically you know, we're trying to deal with different populations, right? We're trying to carve out something for Planned Parenthood and other things dealing with young women, as opposed to old people. So I don't know. I think it works. I mean, it doesn't sound like there will be a lot of places that aren't accredited by Planned Parenthood. What about some of the other things that had comments? I don't know what they were. Can't remember it. Some of the other organizations.
So, do you mean some of the other organizations that are on the list or the ones that commented at the hearing?
Comments against this. And we want to be sure that they are carved out as well. Or figure out that they're not carved out, which may change what we do for people.
So Karen, in this rule, they can't use adjuvant things like opiates and stuff. I thought that was in here.
Yeah,
if
we're
I
trying to
recall.
get rid of that, but I don't know what else is in there.
I don't know.
We have some folks
Any
that
other
are
carve-outs
making
for
some
anyone who's,
comments about this on chat.
yeah, I see.
Yeah.
So, but to Dr. Domino's question, I don't think we have any
Right.
other carve-outs besides that list of folks that
Yeah, I didn't
are
think
in.
so either.
Okay.
I mean, it does talk here about, I mean, you mentioned benzodiazepines.
Yeah, they're not allowed to use this with anything else, basically.
Yeah, okay.
So
Right.
It's
Yeah.
still,
It's
they
in
could
the-
be asleep at 50% nitrous in a urology clinic with an 80-year-old, but that's okay.
Did that answer your question, Dr. Domino?
Yes, you found it. I thought we had benzos and sedatives in it.
Yeah.
I thought we had opioids, but I didn't know where. I was trying to find it.
Okay, and then one of the comments in the chat is that this is from Planned Parenthood, is that they were imagining, let's see, we were imagining it in one section or the other, and they're talking about this clarification. I thought it would be clearer under section 2. The reason it's under 1 is because 1 is the main paragraph and we want to make it up front that this whole section doesn't apply to the facility credit to that 601.5A. So everything below this, if you are an accredited or certified organization that's been approved under 601.5A, then below this is going to apply to you. So you wouldn't have to adhere to anything below 1.
Right.
Like nothing in this section would apply to you. So I think for rule writing purposes, it would, it needs to live in 1.
I
But
agree.
I'm fine if we want to put it.
Yeah. I think it's great where you have it pretty straightforward for the rest of the
Basically,
document.
that sentence, you stop reading. It doesn't apply.
Right. Exactly. Right.
Yeah.
Yes.
Yeah.
Yeah, it doesn't
think it's
apply.
good.
You don't, yeah.
Yeah.
Let's move on.
Okay. So make sure I have everything I need. Hold on. So to Planned Parenthood's comment, they also had a suggestion that we remove the term licensed under 2CV. But then we had this clarification that came out of the hearing. I would ask that maybe Heather provide some
Mhm.
feedback on if they're not licensed. I mean, I understand what the folks at Planned Parenthood are saying, but if we removed license,
It's just they're carved out. So if this doesn't apply to them, what we're trying to deal with is say a lot of older people who may have comorbidities that use quite a bit in cancer surgery, less, you know, and people have cancer and having different procedures like for prostate biopsies and prostate radiation therapy and that. And these folks are older, right? And they have comorbidities. They're not a 20-year-old or a 30-year-old young woman who is at risk. So if they're carved out, why not just keep it there as a appropriate? It makes it safer.
But they aren't always carved out, Karen.
I know, I understand, but if you're taking 1 or 2% of the group that will have it compared to a large proportion of the group, is it worth modifying the safety for people who are old and men too as well? I mean, really, is it? And I don't know. You know, is
I
a
don't
medical
think-
assistant appropriate? I'm not sure it is. If
Well-
they're trained in it and they know how to monitor vital signs, and then I think maybe that might be okay. But I'm saying this is an issue of one of who it's applying to.
Right, but even in a urology clinic, when you're doing a biopsy, often who is assisting you is an MA. You wouldn't necessarily have an LPN or an RN assisting you. You might, but you often wouldn't, right, in an outpatient setting. So I think it's kind of a fair comment because MAs do assist on a lot of procedures in the
What
office.
about dental hygienists? Are they licensed? I mean, maybe the word licensed is an issue. It's just a lot of medical assistants. Some are qualified perhaps and some aren't.
Well, some they're certified or they're registered,
Yeah.
which is a little bit different from being licensed. I don't know. I put in some suggested language. Oh, it looks like Mike has a comment.
go ahead, Mike.
Oh, I'm sorry, Dr. Curry, I didn't see your suggested language, but I wanted to point out that the initial intent was merely to mirror the requirement in 601. So maybe Amelia, you could show them that language that's already existing in the OBS rule. It's subsection 10.
Mike, isn't 601 though for moderate to deep sedation as opposed to?
Yeah, it is. And that's
Like,
why we have,
so
that's why we have two rules. But the at least initially when we were drafting this, what we wanted to do was to remove the accreditation or certification requirement for people who use nitrous oxide. Now we've gone well beyond that, imposing other requirements. But this was meant, at least initially, to impose those same requirements in 601 and 603, except for the accreditation. So here under 10B, you can see the last sentence: the licensed healthcare practitioner who administers intravenous medications and monitors a patient under deep sedation or analgesia must not perform or assist in the surgical procedure. If you like that language, we could use that language in 603.
I mean, this is nitrous oxide is moderate sedation. Okay, so that's what we're trying to be similar. I'm happy with that language. It's confusing about the other language. It just says licensed healthcare practitioner.
So this was Dr. Curry's suggested language to say the person administering the nitrous oxide must be different from the licensed healthcare provider performing the procedure. The medical personnel who are administering the nitrous oxide must be fully trained and competent in nitrous oxide administration and patient monitoring. I mean, that clears up the issue for Planned Parenthood. I mean, I realize they're not part of that.
Not part of it. So,
But as Dr. Curry mentioned, not all
well, could it be
physicians
maybe
are
the word
accredited.
licensed is,
Right, that's what they wanted us to remove. But
yeah.
I mean, I don't know how you feel
don't-
about this language, Mike, but that Dr. Curry's suggesting.
Oh, I don't have a problem with it. I
Uh-huh.
just wanted to mention just the fact initially we wanted to mirror the same language. So I just wanted you to be aware of the language in 601. And if you want to make 603 different, that's fine. If you want
I
to,
think it,
if you want the person administering the anesthesia or the
Well, we
nitrous
can
oxide,
remove the word healthcare license if that's confusing and restrictive. I mean,
Well,
as opposed to
Right.
like a secretary. I mean,
Right.
so,
I mean,
you know,
don't we want to be a little bit more, I mean, that's just it. If you don't put in something, if they said the admin secretary did it because nobody was around and we grabbed her, I mean, how are you defining this as the appropriate person to administer the nitrous oxide?
to be
do we need to
trained and
spell
competent in it.
Yeah. Do we need,
Rather than,
so
yeah,
their medical personnel specifically, trained and competent, do we need to actually say certified or registered medical assistants or licensed? Because
I
there isn't
think
really
so.
any other choice, right? You either have certified
Well-
or registered MAs, or you have LPNs, RNs, et cetera, that are all licensed. And the
Yeah.
person doing the procedure has to be a licensed healthcare provider, not a physician. I thought somewhere it might have said physician, because it could be a PA or an ARNP or an
Right.
MD.
we only do PAs and MTs, right? So that's why
Right.
I think we have physician, not nurse.
Yeah. I wouldn't want someone at a healthcare institute to take language that could get them in trouble when a surveyor walks in. You know, you want to have it be someone who's capable and licensed to do this and not just the admin assistant in the OR area. So just to cover those bases, however we want to word that.
I mean, if we spell out medical, what a certified, registered, whatever they are, medical assistant or
So this
other
is-
licensed healthcare professional. I mean, I
Yeah,
don't-
this
That's good. That's good.
That's a
Erin.
good one.
Yeah.
So this is Heather. I would not, I'm not clear, and the medical assistant program is not clear that this
Mhm.
is within the scope of all medical assistants.
Right.
So,
Yep.
I
Agreed.
think if you're concerned with the word licensed, a lot of times for kind of talking general, they say credentialed, or you could say licensed, registered, or certified healthcare provider acting within their scope. So
I like
you
that.
know that
Yeah.
it's a person
like
who's,
that.
because not all medical assistants, some are just medical assistant phlebotomists, some are medical,
Right.
you know, there are different levels. And so if you just said licensed
Right.
or credentialed, but healthcare provider acting within their scope, then
Yeah.
it's, you know, if it's an LPN, that's fine. If it's RN, if it's a MA, that's within their scope.
Right, I like that. Micah had
that.
appropriate, yeah, just to make it no loopholes for someone who's not, who shouldn't be doing it, to do it, yeah.
And then part of the issue that we're doing right now is that this part makes it clunky having it in the middle of the sentence, other than the physician performing. That's why I think this was a
Do you
little more
want to
clear.
put it somewhere else? The physician performing, you could put it at the end, right? The physician performing the procedure. I don't know where.
Well, I
Yeah.
like the way
Physician or
that
PA.
Dr. Curry started.
It's the person, and person is, yeah.
It's different from, and then we could say the licensed, appropriately credentialed or registered healthcare provider. And then
But-
say.
So could
Having
you,
it in the middle of the
could you,
sentence is confusing.
yeah, so instead of the person administering, could you say the, whatever language we were going to use for the appropriately credentialed or?
You could just
Um,
say provider.
yeah, the provider administering the nitrous oxide must be different. Yeah.
See,
I just want to ask, is it confusing to say provider since people think of providers as being physicians?
Docs.
Yeah. I was thinking,
we
what
could
about we
say
say
the
the
healthcare
professional or
I
the,
want you to, the healthcare
I don't know.
provider.
That's why that's why I switched to person, because I was like, ooh, if you
Yeah.
say provider, that sounds like doctor. And if you say
Or the health-
professional,
Yeah,
healthcare professional, or does that also sound like?
healthcare, you
No,
can say
well, in the
healthcare
there are
past-
lots of
provider.
healthcare professionals.
Yeah, healthcare provider, those could be nurses, they could be,
in the past, we've said practitioner. Does that cover all bases or does that say doctor?
That's good. Yeah. Well, no, that's a
no,
little
that's
more
more,
general.
more physician,
That's okay.
yeah,
Was practitioner okay?
okay. The
Yeah,
healthcare
'cause
practitioner,
provider came into the lexicon because PAs and ARMPs and things were kind of like upset that it's like was always doctor versus whatever. And so provider was meant to encompass sort of a higher level.
Mhm,
You don't usually call like an MA a provider or even an
mhm, mhm.
LPN. So I think practitioner is good.
Yeah. Yep.
Hopefully we didn't make this super muddy just now.
And I really like the language that acting in their scope that Heather suggested.
Yeah,
Okay.
yeah, I do too.
So do
Acting
you want
within
it to
their
say,
scope.
just say that and
You know what, Amelia? I
competent in
can't,
nitrous oxide,
it's,
or just say
I can't read it. Can you read what
I'm
you
sorry.
wrote? I'm sorry. It's too small
Oh, it's too small.
for
Yeah.
me.
Well, that's amazing because I've had complaints it's too big.
Oh my gosh.
that's getting
no,
better.
That's much better. Thank you. Thanks, Amelia.
Must be
That's
training
okay.
measurement. You want to just add on and acting within their scope at the end of that last sentence?
Must be trained and competent, well, or must be trained and competent in nitrous oxide administration and patient monitoring and acting within their scope, right?
Scope of practice.
Scope of
Practice,
practice.
yeah.
Yeah.
Okay, we added more words. Dr. Howe would be very disappointed in us, but if it makes it more clear.
I think clarity is the key.
Yeah.
Yes.
Okay, do we like this now? That
Yes.
we've butchered it all up.
I mean, we do, the one thing is the license appropriately credentialed and registered healthcare practitioner performing the procedure. I thought a lot of the
We
things
didn't-
that have come through, and Mike, maybe you could say, don't we say physician or physician assistant or something, or what do we, I know we say practitioner, but then we don't need to have all the other words of license, appropriate credentials, and registered healthcare practitioner performing the procedure. We're not writing something for nurses, right? Because they don't follow our rules.
All of
Right,
those words
so-
in the first sentence were meant to be related to the person that's administering, not
Right.
the person who's doing the procedure. The person doing the procedure has to be licensed because they are going to be a physician, PA, or ARMP, for example.
Mhm.
So you can take those out of that first sentence. They're mainly,
Okay, hold on.
but we confused you, Amelia. Sorry. That was our
That's
fault.
okay. So you're wanting to change that first sentence around to take all that out?
Okay, hold on.
What?
Should be physician, right?
Why? Yeah.
Yeah, from the physician. Yeah.
Yeah. Thank you. Well, could it
What if it's not a physician? I know we,
I was just gonna say,
We only have
What if-
PAs and
what
physicians
if,
that we deal
yeah,
with.
what if it's not? Should we put in PA also?
physician
No,
slash
because
PA?
this, no, because this
Mm-hmm.
rule is specific to MDs.
Got it. Thank you,
Okay.
Amelia.
So
Yeah,
we
Sorry.
do not have this section in the PA.
thanks for the
Thank you. That
clarification.
makes sense.
Yeah. Yeah,
Do
we're,
we need to add in, do we care about all of that licensed, blah, blah, blah? Can we just leave it, the healthcare practitioner administering the nitrous oxide must be trained?
yes,
Yeah,
Okay.
that's fine the way it is. It's
yeah.
better.
Okay. Okay. Did we cover all of these comments? Oh, they're wanting some clarification about the meaning of, they aren't always carved out. People who are on the list, meaning they could be taken off the list at some point. I don't even, so we haven't had, the only time we went from that list is when one of those facilities went, or accrediting bodies went out of business. We had one that went out of business several years ago. So I'm not really sure, clear up that confusion. So Jessica, or Dr. Guh, can you tell us, are you accredited by someone on that list, by a accrediting entity on that list? Your clinic? I don't know if you can speak, but it's the list.
They're credited
Oh, okay.
by now. Yeah.
Oh, okay. So, yeah, exactly. Okay. Whew, glad we cleared that up. Okay. Drag this out of the way again. Okay, so then back to
I think the confusion is, I don't know if it was you, Karen, that said, Dr. Domino, they aren't always carved out. I think that's that was the concern. That's the question that's in the chat.
But this would allow an MA to help.
oh, they're talking about people that are carved out on the list. That are exempt. So if a clinic is accredited by any of the exempt from 603, the new section that we're talking about. I think that's where the confusion is.
Okay, I just wanted to make sure she was okay. She just put something back in chat. Maybe Dr. Good doesn't
So
have a speaker.
maybe they rather type. Some people don't
I
like.
think what they're
Okay,
saying,
got it,
yeah,
got
is the they were the clinics that aren't accredited, that have no accreditation.
Bonnie, can you try to unmute?
Yeah, I'm looking
Dr.
for
Guh?
her right now. There she is. Got her.
Oh, it says
Oh,
that she's
yeah.
self-muted.
Yeah, it's
Yeah.
not
You may have to,
allowing me to.
so you may have to phone settings. I have found that Teams doesn't always like take your normal settings. You have to go up to the little down arrow next to the microphone and change it to whatever microphone you're actually using. So I want to go back to this comment from Dina Levin. So if you are accredited by an entity that's not on this list, then your clinic would not be exempt from these rules, should they be adopted. And if you're not able to speak, then it's probably because, again, your microphone settings would need to be changed because Teams is finicky.
So if they're not exempt, should
Yep.
it be adopted?
That's correct, Tina. The rules would
Yes.
apply to
Yes.
Yeah.
you.
Yeah. Correct.
Says self-muted, so. Okay, so I think we answered all the questions in the chat. Unless someone has another question, feel free to raise your hand or put it in the chat and we will get to you as soon as possible. So delete this thread. We're good with this language now. Oh,
Yeah.
that's interesting. Let me change some settings real quick. Okay, let me see if I can fix this problem with your microphones. It is weird that they're all giving you problems. Okay, so while I'm doing that, I'm gonna move slowly to the next. Okay, so we received a comment late, which I did email to everyone, but I'm gonna pop it up on the screen here and try to make it big while I try to figure out the settings. They have a suggestion to add this. Is it big enough
I
for
thought it
everybody
was
to read?
fine to add.
Makes sense.
Okay. You should be able to use your microphone then.
Yes, now the unmute is working.
Oh, sorry about that. That was my fault.
No, I'm glad it is sorted. I don't have anything else to add now at this point, but I'm glad I could contribute to the tech problem.
Yeah, thank you. Thank you. Okay. Did everyone have a chance to read this while I went rogue there? Yes?
Fine to add.
Agreed.
And so Dr. Domino says good, Ms. Blake says good. How about you, Dr. Curry? How do you feel about adding? This has significant comorbidities.
Yeah. Good.
And then, so this change here to, my goodness, we have to like, that talks about the scavenging system. We have at the hearing about exempting those who don't have a scavenging system, but they use something else to deal with the leftover nitrous oxide. And so there's a link to this thesis that talks about I'm not going to say that right. Dosimeters? Not the correct pronunciation, I'm not sure. But that is where I picked up some of this information. And then, so we have this edition. So they can use a scavenging system, or they can use a demand flow equipment. And we define that. Or that when they use dosimeters and exposure remains within safe limits. So those are the additions we're making based on comments we received at hearing.
Yeah, I know the demand flow, there's only one out of a whole bunch that have scavengers. You know, blowing nitrous, I mean, people exhale nitrous as well, right? At any rate, I want to look up a little bit more about it. I think the demand ones people use, it'd be good to have doximeters, whether that, I mean, they probably are using the demand systems. If you're not using a demand system and you're just blowing gas, you should have some sort of, regardless of what your doximeter says, you know, you should have scavenging. You shouldn't have it around, but so I thought it was okay as is, but I want to look at it further.
So in wanting to look at it further, does that mean we need to schedule another workshop? Because whenever you decide on this language today, we're bringing it forward to the commission.
Well, we could bring it to the commission and if you
November
want and see what, I won't be at that meeting either. But at any rate, I would like to look at it further.
I thought this language was good and had looked into it a bit since it was the big discussion at the last meeting. So I'm okay to go forward with it.
So we can certainly, if you do have a chance, Dr. Domino, to look at it before November 21st, you can provide some comments between now and then if necessary. But my ask at the end of this meeting today is going to be that the commission, the 3 commissioners that are here, approve this language to go forward to the next step in the rules process. So, and that means that whatever language is here today needs to be the language that you want adopted. So if you want more time, then we'll wait and we'll have another workshop.
You know, it's just of concern for the people who work in the offices. And,
sure,
you know, and in fact, dental offices use scavenging. I mean, the operating rooms, we don't have this drug anymore because it's not a good drug, but I know it's nice. People want to use it for moderate sedation in these settings. But what you don't want to do is harm your staff. And that's all. I think it's fine, but I'm not 100% sure. On the other hand, if you want to move it over, I will remove my opinion from the vote and let the 2 people vote on it, and I won't be there in November. So
I think
then we could bring it back if it just takes more work than I've had time to be able to deal with.
Sure.
Other than looking up that that most of the demand ones are not scavenged. People are advocating for scavenging, but people don't want to spend the money and extra stuff in order to scavenge, which is how dental clinics from a long time and from use in the operating rooms where it still is used is being done, irrespective of any other gases being administered. So you're creating potential hazard for people working in these offices. But I'm just one person on it, and so I'll let the majority rule.
Dr. Domino, can you define scavenging system for me?
What it does is it takes the exhaled gas and gets rid of it. You know, they have these masks they put on, they may not hold it tight, it blows it around the air. But if they exhale into out tubing, it can get rid of it so that it doesn't just sit in the room. And that. So that's what it does, goes to a vacuum the way a suction was.
Okay, thanks.
And you would certainly have a suction, one would think, in these rooms. Anyone we're doing sedation, you should have a suction because people may vomit, especially from nitrous oxide. It's pretty emetic, causes a lot of emesis. One of the reasons it's not used much.
Okay, thanks.
Yeah. So, I mean, fortunately for most, they would be on an empty stomach, but there are people, especially pregnant, further along in pregnancy, have reduced gastric emptying. And that's, so one should have a suction, I assume have available for use, should it be needed, and that's where it is. So it does, I think it's probably fine, but it bothers me. But
So the demand air systems though do require a certain amount of negative pressure. So when you suck in, so when you're just
Yeah.
holding the device and it's not well affixed, it's not right there on the mouth of the patient.
but when they blow out,
it doesn't.
but
I
they
mean,
blow
not,
out right through it, and then it's not hooked
well,
up
they
to
breathe
the
it
suction.
in, and
Yeah, but
you know.
they breathe a breath in, but then you have to exhale before you inhale again, right?
Right, but now they've breathed it in, so, well, anyway, I'm
Yeah,
not
I
gonna.
mean, the gas is still, yeah, you absorb some of it, but some of it goes out, right, in your exhaled air.
So when we
What-
chat about at the
Yeah.
end, when we chat about whether we're going to move this forward or not, then you'll need to make that decision at that
Okay.
time. One of the
Okay,
comments
can I just ask Dr. Domino what it is
from
about
the
this section that
go ahead.
bothers you the most, or that you want to take a look at?
Oh, sorry, it's there. I'm happy with the doximeter. I'm happy with the demand flow. I think that's okay, although it's still, I think there is a risk. I'd rather because you blow it out, it could be in the room. They don't often have doximeters. And then where's the last thing was the one I think, I can't see what it is. Amelia, can you move it up the screen to see? Okay.
Wasn't
Yeah,
it just
that's
those two
fine.
things? I thought it was just those two.
I thought there was a third one, but again, it's been hard to read. So, I mean, it's released during inhalation, but they still blow it out, but that's fine.
So Karen, we did hear that there was some data on with the dosimeters and it was well below any concerning levels.
Yeah,
Also, I thought it was a highly soluble gas, and when you suck it in,
it's
basically
insoluble.
it's quickly like absorbed in the
It's
patient. It's not like
insoluble.
you're.
It goes in. Yeah, but you still blow out, exhale some, right? So I think it's fine. Just
There's-
leave it,
Okay.
you know.
So the comment in the chat is from Planned Parenthood, and it says that they would not be able to install a scavenging system and they are comfortable with the demand flow language. They go on to say our comment reiterated that the demand flow allowance consistent with current interpretive guidance, CDC and OSHA recommendations, and the requirements imposed on dental providers. And she says, I worry that requiring a scavenging system would prohibit most OBGYNs from providing that.
I wasn't talking about that. I was talking about a scavenging system when you're not using the demand flow. If you're just hooking it up to a simple mask.
Oh, like, and that's what this is, though, right? The dosimeter.
I think most of them are using demand flow as well.
Yeah, I'll just also say that it's used incredibly widely in labor wards with the mask, and it captures the. It's used in all over in England. It's used widely, shall I say? So I think the technology is pretty good. Health and safety is a big thing in the NHS, so I
Yeah.
feel like if we're on par with CDC and OSHA, and it's going to be
No,
okay.
that's the demand system or this. So if they want to just
Yeah.
have a mask and they want to use a doximeter, that's okay, I guess. I was assuming that they had the demand system. I thought there was another sentence, so that's fine.
Okay, so are we okay with this language now? No. Yes. Yeah. Okay. I think that is the last piece that we are discussing today. It is. Okay, so does anyone want to go back to any other portions that we talked about?
So I have a question for Mike. Since you know the office-based rules, are we requiring the same sort of monitoring for moderate sedation with nitrous as we do for moderate sedation from IV drugs?
Oh, same type of monitoring?
Well, the same, is this pretty much consistent with what we require for moderate sedation in office-based surgeries?
Yeah, yeah.
I
there are
thought
a
it
few
was,
tweaks.
but I just wanted to make sure. Yeah, they have the suction. Yeah.
Just with a little more specificity. Yes.
So as far as you're concerned, it's fine. I thought we had set it up so that it was originally.
Originally, yes.
Because I mean, I would call this moderate sedation.
Right, right.
Yeah.
The original request was to declare it minimal sedation and therefore completely exempt.
But we call it, this is consistent with moderate sedation and what we required, correct?
Yes.
Yes.
Correct.
Okay, great. All right. That's fine.
Okay. Any other questions?
Do we have a storage requirement in that? That's also an issue. I think we wrote it in there. Dr. Bundy reminded us that it is a substance of abuse.
Like we did, it was towards the end. Sorry.
Yeah, I thought it was at the end.
Stored securely and accessible
Yeah, perfect.
only by authorized individuals. Okay. Let's go to, talked about that already. Written comments. Okay, so at this time, if there's no other questions or comments about the rule language that we've discussed today, it doesn't look like there is, then the panelists, commissioners, if you would please discuss and then vote on language we created today to the next step in the rulemaking process, which is proposed rulemaking or the CR 102. If you do vote for that, we will hold a hearing sometime in the future, probably in January. I have it tentatively scheduled for then. But if we receive more comments, then it may be we have to have another workshop and then etc. So if you guys can discuss and then vote on whether you want to advance this draft to that next step.
Didn't we all agree that it's okay to advance it?
I think we made a lot of progress, and I
Yes.
am grateful for all the comments that we got last time so that we could, you know, improve our rule and take into consideration all the entities that would be having to abide by it. So I think it's ready to go. I feel like we did a lot in the last 2 meetings.
I'm ready to go. Move forward with it as stands with after all the discussion and changes.
Okay, so the next steps for this rule will be that we will request to initiate the CR 102 at the Commission's November 21st business meeting. And then the hearing for this rule, as I mentioned previously, is tentatively scheduled for January. And then Dr. Domino, I think you have a little bit of script.
Okay. That
Actually,
looks
now you're
good.
just
You don't.
yeah,
I
you're just
said,
asking.
well, does anyone
Yeah.
else wish to comment is what I think we're at. Yeah.
Yep.
If I may,
And-
now that my mute button works, this is Jessica Gu from Cedar Rivers Clinic. I just wanted to thank you guys on behalf of myself and the clinic for thinking intently about this, thinking about who could be exempt from this, such as people who are accredited under NAF and the detail in which you guys are pursuing this. So thank you so much and for listening to our comments.
Well, thanks for all your excellent suggestions. All right. And if there's anyone else want to speak at all? If not, I'll close the workshop. Thanks so much.
Thank you.
Thank you, everyone.